I mean, if you're really serious, or
Yeah.
medicate them or
Yeah,
something, yeah.
you're trying to figure out, remember, ICP fluctuates with your activity.
Right.
If you're
Limit your
straining,
activities.
if you're in pain, if you're talking, screaming, if you're curled up in a little ball, your ICP will climb. Anything, and I say this because how many times have I had gone to the ER because the doctor in the ER did an LP and the ICP was 50. The patient was crying in pain and rolled up in a ball. Yes, the ICP will be higher. What you have to do is have people relax. You can't have, if you're trying to figure out how to measure an ICP with a lumbar drain, lumbar tap, you have to have the patient relaxed. But if you have an elevated ICP, first you have to figure out, is this real or not? Is there a trend? Did something happen? And this is what we're trying to, with monitoring, we're trying to say. The treatment threshold would be if the ICP is greater than 25, okay? And I say greater than 25 because some people actually live a little higher. And I would say if someone is GCS of 12 with an ICP of 22, there's really nothing to do. There's people who have pseudotumor cerebri, that means elevated idiopathic intracranial pressure. That's a different thing. But I'm talking about people with trauma. If your goal is to keep the ICP less than 25. If you still feel that the patient could benefit from dropping less than 20, I'd say fine, but it's better to just not over-treat, okay? And then what we're supposed to do here is, other than treating ICP, because ICP, if we go to the box, ICP is just measuring the pressure inside. Then we're supposed to treat the intracranial pressure minus the mean arterial pressure equals a cerebral perfusion pressure. That is the amount of blood that's going and circulating in someone's brain. And why is this important? If the ICP is 50 and your MAP is 50, there's no blood flow. Okay? So you have to have a treatment, and this is that you should keep your cerebral perfusion pressure a minimum of 60. And I wrote here up to 70 because that was the old standard of care. Treat him up to CPP of 70. But that was so complicated, so hard, and then you put all these patients into renal problems because you're using all these pressors when it didn't really make a difference. So they dropped it down to 60. And there's also been an independent predictor, the low mean arterial pressure. Like I said, an ICP minus the mean arterial pressure is the cerebral perfusion pressure. So if your MAP is low, subtract your ICP, your CPP is low too. So that is an indicator. These are the different types of monitors. And the reason I put this picture is, I don't know if John does, is I have a couple options to use when I have my patients. If someone comes in with a subdural hematoma and I'm still concerned of pressure, I'm not going to try and pass a ventriculostomy, because a ventriculostomy is through the brain, down to the ventricles. I have the option of putting a subdural monitor. That just means the dura is here, the skull is here, there's a space between the brain and the catheter, and the dura, and you can put a catheter there, and it gives you a number. It's not the most reliable. The most reliable numbers are always inside, and they're not reliable if you're putting a monitor on the same side you did a craniectomy. Because what happens is you take someone's skull for elevated intracranial pressure, and you remove the skull, you're already changing the dynamics of the skull. So if you put a catheter, a subdural catheter, in someone who had a craniectomy, you might not get an accurate read. The most accurate read would be in someone who has a closed skull with a ventricular catheter. Okay. The other one is a subarachnoid catheter. They don't really work. Intraparenchymal catheters are better. Epidural catheters, not really reliable. The transplant people love asking us to do these epidural catheters. High risk, someone who's in transplant always has coagulopathy, really sick as dog, and they want just to place a monitor in their brain because they're encephalopathic. This is not a good idea, but that's what they make us do. So, simple things on how to manage elevated intracranial pressure. First of all, body position. The head elevated. Some people say, well, what you're doing is you're increasing the venous return, you're decreasing spinal fluid. It really, if you consider all the things you really have to do, is do a reverse to the lumbar, try and keep the head of the bed elevated, and then the next thing you want to do is make sure that the cervical collar is not too tight. because then you're doing compression of the jugular veins and you're causing decreased venous output from the brain. And then the next thing is to blood gas, okay? Who remembers having to hyperventilate for the full hospitalization? Remember that?
About $72.
Yeah, 72, that is,
100% oxygen.
so right there, didn't help, okay? Those patients didn't do that well. What you really want to do is keep the PO2 at least 90 to 100. And there are some PO2 monitors that are out on the scene, and I don't know if we have them here. They're really good for rat studies, but there's really no proof yet that they do better outcomes with patients. The Lycox people try and say, yes, the outcomes are better, but you have to look at the study and say, who did you include? The GCS of 12? Like, did it make sense? So they're trying to make better studies, but it's a good tool if you are doing research, okay? I don't think it's, again, this is my opinion, that it's not as helpful. Why? Because the Lycox monitor is a monitor you put into the brain, and you have to do a separate opening and put a regular ICP monitor. So you have to do 2 stabs into the brain. And if you do a ventriculostomy or a ICP monitor, there's a 1% chance of hemorrhage or any complication associated with a monitor. So you're getting two monitors, plus you're doubling the risk of infection. And I have this picture right here. This guy has a ventriculostomy catheter. This is the old way of protecting your ventriculostomy site. You grab betadine in a 4x4 and you wrap it around the catheter where it exits. There's a better thing now. The antibiotic discs, those are great. There's really no data saying which is better, which is not. But this catheter right here is antibiotic impregnated. This does improve outcomes and decreases infection rates. Outcomes of infection, not outcomes of ICP and everything. I participated in some of the studies at Barrow Neurologic Institute, and they did show some improvement. Before, we used to take out CSF, 3 times a week and everything. But back then, we left the ventriculostomies up to 2 to 3 weeks. So things have changed a little bit. We try not to leave a ventriculostomy catheter more than a week, no more than 10 days, unless there's other issues. And I'll go over how to treat the ICP a little more.
Question for you.
Yes.
With the compression of the jugular venous or jugular veins, are any lines contraindicated with the ventriculostomy?
A lot of people were concerned about doing IJs and everything.
Yeah.
No, there isn't. They were initially concerned about, they were doing some studies, were doing sampling, and they were doing jugular vein sampling. They did not show any worse outcomes than those who did. And this was for blood sampling about tissue oxygenation, but those studies did not show anything. If you occluded, thrombosis, yes, but just putting an IJ.
I think that, as being a nurse, that actually nurses don't pay attention enough to positioning of the head and stuff, and I think a lot of the younger nurses have just never been taught that. I mean, you'll walk in and the patients, they've had a stroke or whatever, they're with trauma and they're sleeping.
Yeah.
They look comfortable, but it's kind of one of those basic things you forget because you're so focused on everything else, and it's so simple. Straighten out their neck and put 2 towels or something there and keep their head elevated. Don't want them flat.
And these are things that we can make. These are the things the easy things we can treat.
Right.
Will it make a big outcome change? I don't know, but if you can modify someone's outcome,
right,
do it. And this is simple. This is not invasive. This is just 22 towels.
right.
Or the other one is just recline the bed a little bit back so their head is not floppy.
Right. And the C-collar thing, I can't tell you how many times I've gone to the floor, and that C-collar is so tight, and it's cut off the circulation to their ears. Their ears are pinned to their head, and they're poor little thing.
Looks so uncomfortable.
You take off the front of it, they're afraid to even touch the C-collar. By keeping, if you just teach them, somebody else can hold the head, take off the front of the C-collar, clean around it, cut it, and then stick it back on.
And one thing I will tell you, everybody's afraid of a collar.
Mm-hmm.
Everybody's paranoid of a collar. Oh, we can't touch it. No, you see the collar.
Can touch it.
you can see the collar, you can actually hold their neck as by precautions, open the collar up. The only times where if you would see sandbags, it's different, you know, sandbags and the tape forehead, or the traction pins.
Initial trauma,
But when
two
they're in
days
the,
later.
yeah, when they're in the floor, especially post-op spine patients or anything, you can take the collar off while they're flat in bed and in neutral spine precautions. You can always take the collar. And if you ever see one of the ER collars, those rigid collars, call the doctor and say, that collar should not be there.
Mhm.
If you haven't cleared the patient within, you know, again, I'm talking about different hospitals. Different policies are time so that the skin doesn't break down. The rigid collars that they put in the ambulance, those little things, they cut down,
Oh, yeah.
they rub, they're actually very bad. If the doctor doesn't know or hasn't cleared, ask them if you can order an Aspen collar or a Philly collar. Those are comfortable collars that you can keep someone definitely and not a problem. The ones that the ER doctors put in, I mean the ambulance people put in, you need to take that off within 24 hours, okay? Because it will start cutting in and you'll get the little picture about
Necrotic ears and chins.
I have a great picture of that. Someone took a picture of someone and my name is at the bottom where they're attending. And it was, I don't want that picture there. But anyway, so again, the positioning is very important. Cervical collar, yes, if you're not comfortable, concerned, ask. You know, nobody, and I'm saying this, if you're ever concerned with any of my patients, ask me about the collar and I'll go over it, okay? And the reason I'm saying that, I'm talking about my patients, okay? John is not a problem, but if any other, if there's locums or anything like that, I would tell you, just ask, okay? Don't take it upon you and all that stuff. So what else do we do? After we maintain the PO2, the PCO2 at least within normal apnea, we try not to hyperventilate. And hyperventilation, I'll say, is good for certain patients. If someone is actively herniated, they blew a pupil, and I'm taking him to the OR, yes, hyperventilate. Bag him until we take him down. What happens? Transient decrease in ICP. And you just want to give them that extra space so when they go to surgery, take the blood clot. The next thing is mild sedation. And this is important in the ICU. If you guys paralyze and sedate someone where I'm concerned about ICP, I know it's not, you didn't do it, the doctor who wrote the order, but it's important to try and get a neuro assessment. Because if a person with elevated ICPs in the ICU, what we need to see is hourly neurochecks. And there's even patients where we say every 15, I know it's like, oh, every 15, but those patients are the ones we're trying to salvage to see if they need to go to surgery or not. So a frequent neurocheck has to be done, and we can use paralytics. Propofol is what some doctors here don't like and others are okay with. Why propofol is good? You stop it, wait 5 minutes, the patient wakes up. Okay? Yes, some people talk about the hyperlipidemia that can be associated in children, and you can use it less than 24 hours. And in adults, you can use it up to 72 hours, and the risk is minimal still. If you use benzodiazepines and narcotics, try to use something short-acting, a little fentanyl drip to kind of keep them comfortable, but try not to use paralytics. And I go to the next one. The ventriculostomy catheter. Once we place the ventriculostomy catheter, we try to leave the reservoir, and this is the opening pressure. And the opening pressure, what it does, think about it as a column of water. If the brain has a pressure of 20 centimeters of water, and that's the pressure that spinal fluid has to overcome before it drains into the bag. If I drop it to 12, that means I'm dropping the column of water, the pressure that has to build up in the brain before the spinal fluid leaves. Okay? So it's important to try and always keep on top of it. And one thing I'll tell you, watch, and I didn't say this, watch people who are doing ancillary, respiratory therapists, physical therapists. People forget about notifying you, removing the patient. What happens? The patient's head is up here. The worst one is where the patient's head is up here and the ventriculostomy is down here, and 20, 30 cc's of CSF just leaked out. That is very dangerous. You can have an acute subdural hematoma from overdraining the brain. In the ventricle, there is 20 cc's of 20